Pets are our family members who can't express their pain through words. As pets age, the need for precise diagnosis of diseases becomes increasingly important. Veterinarians, as the guardians of our pets' health, also need more assistance. These changes create new challenges in diagnostics, requiring solutions that go beyond traditional capabilities. The evolution of medical science from evidence-based medicine to precision and personalized medicine perfectly aligns with G-Links's mission. Since its founding in 2016, G-Links has been dedicated to delivering precise diagnostic solutions, effectively bridging the communication gap between pets and veterinarians. Our business covers more than 20 countries and regions around the world, providing innovative testing services with 20,000 devices over tirelessly pursues innovation, extending goals, reflect our commitment to excellence and reverence for life. The report you use is backed by our dedicated efforts. Over 8,000 installs. The InCycle system is one of the most popular sample-to-answer PCR testing systems in animal healthcare. InCycle brings innovation to the vet in vitro molecular diagnostics testing market, enabling sample-to-answer cartridge-based molecular diagnostics testing. The InCycle platform integrates nucleic acid extraction, purification, and PCR amplification, all within an innovative, fully automated system that combines various detection methods. Manual preparation, cold chain reagents, and the use of multiple devices are no longer required. Our diagnostic solutions are diverse, offering over 20 combo packages for respiratory, gastrointestinal, and vector-borne pathogens. By utilizing comprehensive multi-pathogen detection, we save time and protect more pets. With a correlation of over 90% to standard laboratory instruments, Phytox delivers accurate quantitative results in just minutes. All reagents remain stable at room temperature, enabling simultaneous PT-APTT or PT-APTT FIB-TT results in just 1 minute from a single sample. G-Links's advanced AI data analytics empower you to proactively deliver preventive care, saving time while anticipating potential future illnesses. The future of smart diagnostics relies on AI combined with precision diagnostics, which is precisely G-Links's vision. We are committed to shaping the future of animal health alongside veterinarians, creating a better life for pets. Shaping the future of diagnosis for animal health. Pets are our family members who can't express their pain through words. As pets age, the need for precise diagnosis of diseases becomes increasingly important. Veterinarians, as the guardians of our pets' health, also need more assistance. These changes create new challenges in diagnostics, requiring solutions that go beyond traditional capabilities. The evolution of medical science from evidence-based medicine to precision and personalized medicine perfectly aligns with G-Links's mission. Since its founding in 2016, G-Links has been dedicated to delivering precise diagnostic solutions, effectively bridging the communication gap between pets and veterinarians. Our business covers more than 20 countries and regions around the world, providing innovative testing services with 20,000 devices to over 50,000 veterinarians, ensuring the health of more than 5 million pets yearly. G-Links's R&D team tirelessly pursues innovation, extending technological care to every animal. Our automated production lines and stringent quality controls reflect our commitment to excellence and reverence for life. Every report you use is backed by our dedicated efforts. With over 8,000 installed systems, the InCycle system is one of the most popular sample-to-answer PCR testing systems in animal healthcare. InCycle brings innovation to the vet in vitro molecular diagnostics testing market, enabling sample-to-answer cartridge-based molecular diagnostics testing. The InCycle platform integrates nucleic acid extraction, purification, and PCR amplification, all within an innovative, fully automated system that combines various detection methods. Manual preparation, cold chain reagents, and the use of multiple devices are no longer required. Our diagnostic solutions are diverse, offering over 20 combo packages for respiratory, gastrointestinal, and vector-borne pathogens. By utilizing comprehensive multi-pathogen detection, we save time and protect more pets. With a correlation of over 90% to standard laboratory instruments, Phytox delivers accurate quantitative results in just minutes. All reagents remain stable at room temperature, enabling simultaneous PT-APTT or PT-APTT FIB-TT results in just 1 minute from a single sample. G-Links's advanced AI data analytics empower you to proactively deliver preventive care, saving time while anticipating potential future illnesses. The future of smart diagnostics relies on AI combined with precision diagnostics, which is precisely G-Links's vision. We are committed to shaping the future of animal health alongside veterinarians, creating a better life for pets. Shaping the future of diagnosis for animal health. Pets are our family members who can't express their pain through words. As pets age, the need for precise diagnosis of diseases becomes increasingly important. Veterinarians, as the guardians of our pets' health, also need more assistance. These changes create new challenges in diagnostics, requiring solutions that go beyond traditional capabilities. The evolution of medical science from evidence-based medicine to precision and personalized medicine perfectly aligns with G-Links's mission. Since its founding in 2016, G-Links has been dedicated to delivering precise diagnostic solutions, effectively bridging the communication gap between pets and veterinarians. Our business covers more than 20 countries and regions around the world, providing innovative testing services with 20,000 devices to over 50,000 veterinarians, ensuring the health of more than 5 million pets yearly. G-Links's R&D team tirelessly pursues innovation, extending technological care to every animal. Our automated production lines and stringent quality controls reflect our commitment to excellence and reverence for life. Every report you use is backed by our dedicated efforts. With over 8,000 the FANZCVS system is one of the most popular sample-to-answer PCR testing systems in animal healthcare. FANZCVS brings innovation to the vet in vitro molecular diagnostics testing market, enabling sample-to-answer cartridge-based molecular diagnostics testing. The FANZCVS platform integrates nucleic acid extraction, purification, and PCR amplification, all within an innovative, fully automated system that combines various detection methods. Manual preparation, cold chain reagents, and the use of multiple devices are no longer required. Our diagnostic solutions are diverse, offering over 20 combo packages for respiratory, gastrointestinal, and vector-borne pathogens. By utilizing comprehensive multi-pathogen detection, we save time and protect more pets. With a correlation of over 90% to standard laboratory instruments, FIDEX delivers accurate quantitative results in just minutes. All reagents remain stable at room temperature, enabling simultaneous PT-APTT or PT-APTT FIB-TT results in just 1 minute from a single sample. G-Linx's advanced AI data analytics empower you to proactively deliver preventive care, saving time while anticipating potential future illnesses. The future of smart diagnostics relies on AI combined with precision diagnostics, which is precisely G-Linx's vision. We are committed to shaping the future of animal health alongside veterinarians, creating a better life for pets. Shaping the future of diagnosis for animal health. Pets are our family members who can't express their pain through words. As pets age, the need for precise diagnosis of diseases becomes increasingly important. Veterinarians, as the guardians of our pets' health, also need more assistance. These changes create new challenges in diagnostics, requiring solutions that go beyond traditional capabilities. The evolution of medical science from evidence-based medicine to precision and personalized medicine perfectly aligns with G-Linx's mission. Since its founding in 2016, G-Linx has been dedicated to delivering precise diagnostic solutions, effectively bridging the communication gap between pets and veterinarians. Our business covers more than 20 countries and regions around the world, providing innovative testing services with 20,000 devices to over 50,000 veterinarians, ensuring the health of more than 5 million pets yearly. G-Linx's R&D team tirelessly pursues innovation, extending technological care to every animal. Our automated production lines and stringent quality controls reflect our commitment to excellence and reverence for life. Every report you use is backed by our dedicated efforts. With over 8,000 installed systems, the FANZCVS system is one of the most popular sample-to-answer PCR testing systems in animal healthcare. FANZCVS brings innovation to the vet in vitro molecular diagnostics testing market, enabling sample-to-answer cartridge-based molecular diagnostics testing. The FANZCVS platform integrates nucleic acid extraction, purification, and PCR amplification, all within an innovative, fully automated system that combines various detection methods. Manual preparation, cold chain reagents, and the use of multiple devices are no longer required. Our diagnostic solutions are diverse, offering over 20 combo packages for respiratory, gastrointestinal, and vector-borne pathogens. By utilizing comprehensive multi-pathogen detection, we save time and protect more pets. With a correlation of over 90% to standard laboratory instruments, FIDEX delivers accurate quantitative results in just minutes. All reagents remain stable at room temperature, enabling simultaneous PT-APTT or PT-APTT FIB-TT results in just 1 minute from a single sample. G-Linx's advanced AI data analytics empower you to proactively deliver preventive care, saving time while anticipating potential future illnesses. The future of smart diagnostics relies on AI combined with precision diagnostics, which is precisely G-Linx's vision. We are committed to shaping the future of animal health alongside veterinarians, creating a better life for pets. Shaping the future of diagnosis for animal health. Pets are our family members who can't express their pain through words. As pets age, the need for precise diagnosis of diseases becomes increasingly important. Veterinarians, as the guardians of our pets' health, also need more assistance. These changes create new challenges in diagnostics, requiring solutions that go beyond traditional capabilities. The evolution of medical science from evidence-based medicine to precision and personalized medicine perfectly aligns with G-Linx's mission. Since its founding in 2016, G-Linx has been dedicated to delivering precise diagnostic solutions, effectively bridging the communication gap between pets and veterinarians. Our business covers more than 20 countries and regions around the world, providing innovative testing services with 20,000 devices to over 50,000 veterinarians, ensuring the health of more than 5 million pets yearly. G-Linx's R&D team tirelessly pursues innovation, extending technological care to every animal. Our automated production lines and stringent quality controls reflect our commitment to excellence and reverence for life. Every report you use is backed by our dedicated efforts. With over 8,000 installed systems, the InCycle system is one of the most popular sample-to-answer PCR testing systems in animal healthcare. InCycle brings innovation to the vet in vitro molecular diagnostics testing market, enabling sample-to-answer cartridge-based molecular diagnostics testing. The InCycle platform integrates nucleic acid extraction, purification, and PCR amplification, all within an innovative, fully automated system that combines various detection methods. Manual preparation, cold chain reagents, and the use of multiple devices are no longer required. Our diagnostic solutions are diverse, offering over 20 combo packages for respiratory, gastrointestinal, and vector-borne pathogens. By utilizing comprehensive multi-pathogen detection, we save time and protect more pets. With a correlation of over 90% to standard laboratory instruments, FIDEX delivers accurate quantitative results in just minutes. All reagents remain stable at room temperature, enabling simultaneous PT-APTT or PT-APTT FIB-TT results in just 1 minute from a single sample. G-Links's advanced AI data analytics empower you to proactively deliver preventive care, saving time while anticipating potential future illnesses. The future of smart diagnostics relies on AI combined with precision diagnostics, which is precisely G-Links's vision. We are committed to shaping the future of animal health alongside veterinarians, creating a better life for pets. Shaping the future of diagnosis for animal health. Pets are our family members who can't express their pain through words. As pets age, the need for precise diagnosis of diseases becomes increasingly important. Veterinarians, as the guardians of our pets' health, also need more assistance. These changes create new challenges in diagnostics, requiring solutions that go beyond traditional capabilities. The evolution of medical science from evidence-based medicine to precision and personalized medicine perfectly aligns with G-Links's mission. Since its founding in 2016, G-Links has been dedicated to delivering precise diagnostic solutions, effectively bridging the communication gap between pets and veterinarians. Our business covers more than 20 countries and regions around the world, providing innovative testing services with 20,000 devices to over 50,000 veterinarians, ensuring the health of more than 5 million pets yearly. G-Links's R&D team tirelessly pursues innovation, extending technological care to every animal. Our automated production lines and stringent quality controls reflect our commitment to excellence and reverence for life. Every report you use is backed by our dedicated efforts. With over 8,000 installed systems, the InCycle system is one of the most popular sample-to-answer PCR testing systems in animal healthcare. InCycle brings innovation to the vet in vitro molecular diagnostics testing market, enabling sample-to-answer cartridge-based molecular diagnostics testing. The InCycle platform integrates nucleic extraction, purification, and PCR amplification, all within an innovative, fully automated system that combines various detection methods. Manual preparation, cold chain reagents, and the use of multiple devices are no longer required. Our diagnostic solutions are diverse, offering over 20 combo packages for respiratory, gastrointestinal, and vector-borne pathogens. By utilizing comprehensive multi-pathogen detection, we save time and protect more pets. With a correlation of over 90% to standard laboratory instruments, Phytox delivers accurate quantitative results in just minutes. All reagents remain stable at room temperature, enabling simultaneous PT-APTT or PT-APTT FIB-TT results in just 1 minute from a single sample. G-Links's advanced AI data analytics empower you to proactively deliver preventive care, saving time while anticipating potential future illnesses. The future of smart diagnostics relies on AI combined with precision diagnostics, which is precisely G-Links's vision. We are committed to shaping the future of animal health alongside veterinarians, creating a better life for pets. Shaping the future of diagnosis for animal health. Pets are our family members who can't express their pain through words. As pets age, the need for precise diagnosis of diseases becomes increasingly important. Veterinarians, as the guardians of our pets' health, also need more assistance. These changes create new challenges in diagnostics, requiring solutions that go beyond traditional capabilities. The evolution of medical science from evidence-based medicine to precision and personalized medicine perfectly aligns with G-Links's mission. Since its founding in 2016, G-Links has been dedicated to delivering precise diagnostic solutions, effectively bridging the communication gap between pets and veterinarians. Our business covers more than 20 countries and regions around the world, providing innovative testing services with 20,000 devices to over 50,000 veterinarians, ensuring the health of more than 5 million pets yearly. G-Links's R&D team tirelessly pursues innovation, extending technological care to every animal. Our automated production lines and stringent quality controls reflect our commitment to excellence and reverence for life. Every report you use is backed by our dedicated efforts. With over 8,000 installed systems, the InCycle system is one of the most popular sample-to-answer PCR testing systems in animal healthcare. InCycle brings innovation to the vet in vitro molecular diagnostics testing market, enabling sample-to-answer cartridge-based molecular diagnostics testing. The InCycle platform integrates nucleic acid extraction, purification, and PCR amplification, all within an innovative, fully automated system that combines various detection methods. Manual preparation, cold chain reagents, and the use of multiple devices are no longer required. Our diagnostic solutions are diverse, offering over 20 combo packages for respiratory, gastrointestinal, and vector-borne pathogens. By utilizing comprehensive multi-pathogen detection, we save time and protect more pets. With a correlation of over 90% to standard laboratory instruments, Phytex delivers accurate quantitative results in just minutes. All reagents remain stable at room temperature, enabling simultaneous PT-APTT or PT-APTT FIB-TT results in just 1 minute from a single sample. G-Links's advanced AI data analytics empower you to proactively deliver preventive care, saving time while anticipating potential future illnesses. The future of smart diagnostics relies on AI combined with precision diagnostics, which is
Okay. Dear veterinary professionals and valued G-Links partners, welcome to G-Links Academy and welcome to today's G-Links seminar, Mastering FLP, Confident Diagnosis to Successful Treatment. And this is Kevin from G-Links, and I'll be your host for today's online session. We're so glad to have you with us today, whether you're joining us live or catching the replay later. Feline Infectious Peritonitis, or FLP, continue to be one of the most challenging diseases in the feline medicine, and today's session is designed to help you approach it with a greater confidence from accurate diagnosis to successful treatment. And it's our great pleasure to welcome Dr. Alison Jukes, Fellow of the Australian and New Zealand College of Veterinary Scientists. She also serves as a mentor in the University of Sydney distance education programs. With over 16 years clinical experience, Dr. Jukes brings profound expertise and unique insights into the diagnosis and management of FAP. And please kindly note that all the contents presented in this webinar is intended for academic and educational purpose only. It does not consist to any forms of diagnosis, treatment, or medication guidance. Thank you so much. And now let's leave the time to Dr. Alison Jukes and her professional presentation.
Good evening. My name's Alison Jukes. I'm a feline internal medicine specialist working at Cat Specialist Services in Brisbane, Australia. And this evening, we're going to have a talk about feline infectious peritonitis. And the goal of the talk today really is to improve understanding of this disease, also improve our understanding of different diagnostic tests that we can perform so that we can obtain a diagnosis of this disease, and then we shall have a look at different treatments available as well. So as a bit of an overview, in the first part of the talk, we'll discuss FIP, pathogenesis and pathophysiology. Then we'll talk about how we obtain a diagnosis, looking at our patient overall from signalment to laboratory testing and more specific testing for FIP and feline coronavirus. In our part 3 of the talk, we will go specifically through cases of cats with a diagnosis of feline infectious peritonitis, as well as some cases which looked like feline infectious peritonitis, but were actually other different disease processes. And then our last part of the talk, we will have a look at the updates on feline infectious peritonitis treatment, with a particular focus on some of the newer antivirals that are available to us. So, starting off with FIP pathogenesis and pathophysiology, and I'm quite passionate about understanding disease process and how different diseases occur and what they do to our patients. If we can understand the pathogenesis and the pathophysiology of disease really well, then it can help us understand why our cases present with the clinical signs and laboratory changes that they do, and it will make all of us better clinicians. So we'll start here. And so, as I'm sure we all know, when we're talking about feline infectious peritonitis, the causative agent of this disease is feline coronavirus. And feline coronavirus is an RNA virus. It is present in cats worldwide. And when we have a patient infected with feline coronavirus, it typically will cause pretty mild disease, but if we have a patient in which they develop FIP, then this disease is uniformly fatal unless treated. When we're considering cats with FIP, the most commonly affected cats are pedigree cats and young cats less than 2 years of age. The disease itself is commonly described as a wet form versus a dry form. A wet form is where we see effusions, commonly pleural or abdominal effusion, sometimes pericardial or scrotal. And a dry form is when we have granuloma formation in various organs such as kidneys, lymph nodes, or the large intestine. We can also see neurologic versions of the disease and ophthalmic or uveitis as well. And when we're trying to obtain a diagnosis, it's really important to consider that it's not just a single test which is going to give us a diagnosis, but it is a collection of different aspects of the patient which will make us suspicious or lead us to that diagnosis. And so foundational, it's really important to have a good clinical history and physical examination of our patient. Often we'll then do some blood tests, perhaps some imaging and sampling of affected tissues. And then there are some coronavirus specific tests that we can do, including PCR, as well as immunostaining for virus particles via immunocytochemistry on fluids or cytology samples, or immunohistochemistry in tissue samples. So, as a little bit of a review of feline coronavirus, it is a large enveloped positive sense single-stranded RNA virus. And as I said earlier, there is a worldwide distribution of this particular virus. One of the features of coronavirus is that it does have a high mutation rate during RNA replication, and this probably aids this virus in mutation from coronavirus that lives in the gut to FIP virus. And so when we're talking about the enteric version of a feline coronavirus infection, it is generally pretty mild disease. And these patients, if they're infected with feline coronavirus causing an enteric infection, typically they'll have a mild and self-limiting diarrhea, which may only last a few days, if that. If we see the coronavirus mutate to FIP-related disease, that's when we start to see multifocal organ systems affected and quite severe disease and untreated. This is a fatal disease. Feline coronavirus has two different serotypes, type 1 and type 2. So type 1 is the most common serotype that's seen in the field. However, type 2 is more easily grown in cell culture. And it's thought that type 2 arises from a recombination between a feline coronavirus and a canine coronavirus. As I mentioned before, these coronaviruses have really high mutation rate. And so when they're replicating, the RNA polymerase commonly mutates and causes errors in the genetic code. And that's really important when it comes to that change in tropism from a coronavirus that likes to hang out in the gut to a coronavirus that then has a tropism for our monocytes and macrophages and then causes systemic spread. And systemic spread really is dependent on entry of the coronavirus into the host cell. And the coronavirus does this via their spike protein. And there's two subunits in the spike protein, subunits S1 and S2, and they require recognition by the feline host cell receptor. And it is thought that mutations in the S2 fusion domain, specifically a methionine to leucine at position 1058 and a serine to alanine at position 1060, that are associated with FIP. Although this isn't always the case. And so the spike protein is really important for that mediation of viral entry into the host cell. And when we look at the research that's done into how this happens and what mutations are involved from an enteric coronavirus to an FIP coronavirus, then the evidence seems to show that there's a combination of different mutations that occur. So it's not just one single mutation, but potentially a whole host of mutations that result in that change from an enteric coronavirus to an FIP virus. When we think about the epidemiology of feline coronavirus, it is a really common virus in cats which live in multi-cat environments. And so when we think about multi-cat environments, it's not just the household which has more than one cat, but also shelters and breeding catteries. when we look at cats which live more solitary lives, and so, for example, there has been some research done all over the world, but in particular in my part of the world in Australia, there are a large number of feral cats which live unowned with very minimal human contact, and the prevalence of coronavirus in that particular population is exceedingly low. Again, when we think about the types of cats which are prone to coronavirus exposure, it's pedigree cats and young cats, although cats at any age can encounter coronavirus and seroconvert to it. The virus is transmitted cat to cat via a fecal-oral route of transmission. And you can get fecal shedding as soon as 2 days after exposure. And this shedding from the feces can last weeks to months. In some cats, you can have persistent infection, or these are kind of cats which have a carrier state and they shed virus into the environment. And that's thought to be about 13% of cats. The majority of cats will just have a transient infection. However, unlike some viral diseases, immunity to coronavirus is quite short-lived. And so if a cat has been exposed to coronavirus at one point in time, then months to years later, if they're exposed again, they are likely to develop in another infection again. When we think about feline coronavirus titers, so antibodies against coronavirus, higher titers are associated with higher amounts of fecal shedding, and this is in particularly in kittens. So when a cat is exposed to feline coronavirus, if it's an uncomplicated infection, they may have some mild intestinal signs, so maybe a little bit of diarrhea. And the virus will replicate in the gut. It may then spread to the mesenteric lymph nodes as well. If that particular cat has an unsuccessful host immune response, then we can see the development of FIP. If the cat has an okay, but maybe not a great immune response, then that cat may become a chronic shedder. And so these are the cats that are chronically, losing coronavirus into their feces. One important consideration, so if you have a cat which has a really great immune response and manages to clear that infection, even healthy cats, if they have been exposed to coronavirus, they can have low numbers of systemic coronavirus circulating. And their viremia can last 1 to 2 weeks. Sometimes we may have a situation where there seems to be an outbreak of FIP either in a shelter or a breeding cattery. And this, however, is probably just due to large numbers of cats being exposed to large amounts of coronavirus, and then if they're stressed because they're housed intensively, then developing FIP. Horizontal transmission of FIP virus by itself is thought to be quite rare. And once cats have the mutations which allow feline coronavirus to be systemically spread and become FIP virus, then those cats actually, that particular variant of coronavirus loses its ability to live in enterocytes and be shed through the gut. And so that's why kind of horizontal FIP virus transmission cat to cat is thought to be quite rare. So there are viral factors, and we touched on these before. So the spike protein gene mutation is an important consideration for the change in a regular feline coronavirus to the FIP virus. And if we see some of these spike gene mutations, what they allow that virus to do is to change its tropism from enterocytes in the gut to the monocytes and macrophages, which then allow that viral particle to spread throughout the body. And so what happens is that then once they have that mutation, which allows them to spread into macrophages, then they're able to replicate within those cell lines. And again, just to reiterate, it's not just one gene mutation that results in FIP, it's a multitude of gene mutations that change a kind of relatively benign enteric coronavirus to FIP virus. So host factors which are involved in the development of FIP. So we've looked at the viral factors in the cats which are at risk, but the host immune system is also really important. And the viral load and the virulence of the particular virus is important, but then also an individual's immune system response to FIP will determine whether or not they develop systemic disease or not. Older cats are just better at combating feline coronavirus. And when we think about the acute forms of FIP, this tends to be vasculitis, which results in effusions. And so when you have a vasculitis and you've got inflammation of your blood vessels, they become leaky. And so therefore, forms which tend to come on more acutely tend to be effusive forms of the disease. And those effusions, again, pleural and peritoneal, sometimes pericardial, sometimes scrotal. In the more chronic variant of the disease, these cats seem to have less evidence of vasculitis, so vasculitis is still present, but they have more pyogranuloma formation, and this is kind of what we might call the dry form of the disease. And these granulomas can form in a range of different organs, again, so things like kidneys, lymph nodes, large bowel, myocarditis has also been described, as well as uveitis and central nervous system disease. And the balance of the host immune system seems to play a role in whether or not we see wet form or dry form or develop disease entirely. So it is thought that these cats which are prone to developing FIP have a poor cell-mediated immune response. And then they have, in contrast to that, an excessive humoral immunity. So they have a lot of antibody production, which is not good or effective at clearing that infection. These cats also have cytokine derangements, cytokines just being little cellular signaling molecules which occur in a range of different disease processes. So cats with FIP tends to have higher levels of tumor necrosis factor alpha and decreased tumor necrosis factor gamma. Genetics maybe play a role in the fact that we do see certain breeds which may be more prone. However, some of the evidence around this hasn't really shown causality. The genetic factor may just be more related to people reporting an FIP outbreak in a Burmese cattery or a Bengal cattery, and that may be kind of more an environmental consideration with these cats being housed altogether. And again, younger cats, so age is a really important consideration. And so there's that picture of that basket of kittens, which I've included just to kind of reiterate that it's our younger cats which are more likely to develop disease, and younger cats that are all housed together. When we consider the environmental factors that result in the development of FIP, it can all be really put down to stress. So if we have a situation where there is overcrowding of cats, this can increase the stress in those particular cats. And then if they're exposed to coronavirus, keeping in mind that coronavirus is really highly infectious and really common in our cat population, if you have a stressed individual with exposure to virus, it just allows that virus to replicate more, and then you increase the genetic mutation within those viruses. And so you're more likely to then have a viral mutant which arises, which has the right genetic mutations to allow systemic spread. Also, what can come with overcrowding is poor hygiene and poor litter tray management. And so, again, if you just have not enough litter trays that are dirty all the time and fecal material sitting there, then that just, again, is another way of having increased exposure of the cats in that particular environment to feline coronavirus. Okay, so we'll move on to part 2, which is looking at, well, we've talked about how this FIP can arise, but then if we have a patient that we suspect as FIP, well, how do we diagnose that in a particular individual? So there's a range of different kind of foundational things which we'll have a look at. And I think we've talked about the signalment of these patients, remembering we're talking young cats, pedigree cats, cats from multi-cat environments with high levels of stress. So some of that obviously we'll know from patient that's in front of us, but also really important to take a good history of our owners that are presenting the patient. Physical examination is still a really important part of our diagnostic process, and a really good head to tail physical examination looking at every part of the cat. And then we can consider what type of laboratory tests we do. And I guess what we're ending up doing by this process is trying to figure out, is that sick cat in front of us, have they potentially got FIP? And so talking about the typical presentation, because most cats with FIP will kind of fit this bill. So again, just to really reiterate this, our signalment, so most of these cats will be young cats, they'll be less than 2 years of age. And when I say less than 2 years, it's kind of between, say, 4 months to 2 years. It's pretty uncommon or rare for a cat less than 4 months of age to develop FIP. So we're talking young cat 2 years of age, or between 4 months and 2 years of age. They'll often have come from some kind of multi-cat environment, not always, but often. So I'm talking maybe that cat got rehomed out of a shelter, maybe it's from a breeding cattery, maybe it is from a situation where we've got an owner with 5 or 6 cats in a 2-bedroom apartment. So some kind of multi-cat environment. These cats will often have a history of stress. And when I'm talking about stress, I'm talking environmental stress. And cats, so if they're housed intensively with poor litter tray hygiene, maybe there's some inter-cat tensions because there's too many cats in a small space, whether that's in a home, a cattery, or a shelter. And the owners will typically talk about these cats may have some evidence of weight loss, or particularly if we have a young kitten, maybe 4 or 5 months of age, maybe they haven't lost a whole lot of weight, but they haven't really put on the amount of weight that we might have expected. So you might see that they were a good condition when they presented for their vaccine at 12 weeks of age, and now at 6 months of age, they haven't actually put on a whole lot of weight since that last visit. These cats will often have a history of lethargy, poor appetite. Some of these clinical signs can be waxing and waning. So, so some owners don't necessarily present them the first time that they don't eat a meal because these clinical signs can come and go a little bit over a few weeks. They may have a distended abdomen or dyspnea if they have effusive disease in their tummy or chest. On the physical examination, well, the clinical signs really depend on the location of disease, and not every cat will have disease in every different organ system. But common considerations are cats with pyrexia, which is not necessarily a really severe pyrexia. It may only be a 39.5 degrees or a 39.8 degrees type pyrexia. They may have some obvious jaundice, which I hope you can appreciate just on the photo of this little kitten here. You can see how yellow the skin is in his ears with the light. They may have an effusion somewhere, which, depending on volume, may or may not be obvious on the physical examination. They may have a uveitis, and so it's really important to have a really good look at their eyes and see if you can see anything obvious there. And they may have neurologic signs. So that might be dull mentation or wobbliness or abnormal gait or something along those lines. And again, just to reiterate, we're talking cats with wet form have a vasculopathy and effusions, again, which may or may not be obvious on a physical examination. And then the cats with the dry form have granuloma formation. The reality is most cats probably have a combination of disease, and at post-mortem, most cats with effusive form still have granulomatous lesions somewhere in their body. So the effusive form, again, abdominal, pleural are the most common, and then pericardial and scrotal as well. It can be relatively acute in nature, and it tends to be progressive disease. So, and we're talking progression over days to weeks. Other clinical signs, again, depending on where the disease is, may include dyspnea or tachypnea or abdominal distension. If we have disease within the gastrointestinal tract, we may see changes to regional lymph nodes. You can see lesions within the wall of the colon or the ileocolic junction. These are both pretty common areas. And again, thinking about how the disease spreads, it is an enteric virus, and so it might be expected that it goes first to the regional lymph nodes and the mesenteric nodes before it goes elsewhere. So they're really common places that you'll see changes. If the patient has central nervous system signs, they may have very focal signs, or they can have multifocal disease involving the brain, the spinal cord, or meninges. Some particular variants of CNS clinical signs that have been described are things like a T3 to L3 myelopathy, also central vestibular disease, but I feel as though probably mostly, or commonly, if I'm seeing a young cat with neurologic disease that I'm worried is FAP related, they often have evidence of disease in more than one location. Ocular disease is really common, and this photo is just an example of a cat with a one-sided uveitis, and I hope you can appreciate the hyphema and that change to the iris colour that we can see in this photo. Uveitis can be anterior and or posterior in the eye, and FIP is described to be the second most common cause of uveitis in cats after idiopathic uveitis. And so if you've got a young cat with a uveitis and systemic clinical signs, you've got to be thinking really hard about, does this patient have FIP or not? Skin lesions have been described, although less commonly, but you can have single or multiple nodules or papules, or sometimes an ulcerative dermatitis. And again, rarely there have been described cases of myocarditis and rhinitis in cats with FIP. So how else are we going to obtain a diagnosis? So maybe we have a cat that was suspicious based on its clinical history and its physical examination findings, so we're going to do some tests. So I think blood tests are a good place to start, and we'll just go through some classical changes that we might expect to see. So on our hematology, typically there's non-specific signs, but there are a few things that can stand out. About half to 3/4 of these cats will have a lymphopenia. And again, about 40 to 60% of cats may have a neutrophilia. And really commonly, these cats will have a mild to moderate anemia. So I'm talking about maybe a hematocrit anywhere between 20 to 30%. Often it'll be normocytic and normochromic, maybe with a microcytosis in some instances. You will on occasion find cats which have a secondary immune-mediated thrombocytopenia or an immune-mediated hemolytic anemia, in which case they can present with quite a marked anemia and low platelet crit. So, but keep in mind, most commonly, they have a mild to moderate anemia. And this is probably just as a secondary anemia due to inflammatory disease. With the blood biochemistry, again, we've got non-specific changes, but there are a few that are pretty common in a lot of cats. And so the one that I think probably we all think about is a hyperglobulinemia. And this is described in, up to 90% of cats. And so that's where their globulin count is going to be high. Often concurrently with their hyperglobulinemia, they'll have a hypoalbuminemia. Now, albumin is a negative acute phase protein. And so when we have an inflammatory process going on, particularly a chronic inflammatory process like FIP, albumin will tend to drop. And so it's that combination of high globulin and low albumin. And when we look at the albumin to globulin ratio, most commonly will have a low albumin to globulin ratio. And so if that AG ratio is less than 0.4, FIP is certainly possible. If it's greater than 0.8, FIP is unlikely. However, these are just guidelines, and I don't think that you can just use this as the only marker of a diagnosis of FIP or not. And keeping in mind that we can see low albumin to globulin ratios with a range of other different disease processes, especially anything that causes chronic inflammation. And so common things that you might see may be feline stomatitis or oral inflammation is a really common cause of that hyperglobulinemia and maybe a low AG ratio. Any other chronic infection, whether it's bacterial or other types of infections, can cause a low AG ratio, as well as things like myeloma-related disorders. You can do a serum electrophoresis if you have a hyperglobulinemia, and typically these cats will have a polyclonal hyperglobulinemia, causing their changes that we're seeing on the blood test. Another common clinical finding on our blood biochemistry is a hyperbilirubinemia, and this is described in a variable number of cats, depending on the population, maybe 20 to 60% of cats, more common in cats with effusive disease. And this is a hyperbilirubinemia, which is typically in the absence of a hepatopathy. So the other liver enzymes like your ALT, ALKP, and GGT are often normal. It's not entirely sure why these cats get a hyperbilirubinemia. It's thought that maybe they have some increased red cell fragility, which goes along with that chronic inflammatory process in FIP. However, again, hyperbilirubinemia is not specific for FIP. We can certainly see it elevated in other systemic diseases such as sepsis and pancreatitis, and they're some of the diseases which can be what we're trying to rule out if we're getting a diagnosis of FIP. So more specific or laboratory testing that you can do include measuring positive acute phase proteins. And so acute phase proteins are proteins that are affected by inflammation. They're produced by the liver. But again, FIP is not the only inflammatory disease that can affect their production. And they're produced in response to cytokines, which are released from monocytes and macrophages, again with chronic inflammatory conditions or acute and severe inflammatory conditions. So the major acute phase proteins in cats are alpha-1 acid glycoprotein and serum amyloid A. Access to these tests can be a little bit dependent on where you are in the world. But if you do have availability of them and you can measure them, so the alpha-1 acid glycoprotein tends to be markedly elevated in FIP and greater than 1.5 milligrams per mil with suggestive signs is suggestive of FIP. Feline coronavirus serology is another blood test that can be done to look for evidence of a patient's exposure to coronavirus. Now, at this time, we don't have antibody serology that differentiates between FIP coronavirus and enteric coronavirus. And so if we're measuring coronavirus antibody levels, then this is just telling us whether or not a cat has been exposed to coronavirus and whether or not they have seroconverted. Cats with FIP tend to have higher coronavirus titers, but there is a big overlap between cats with FIP and cats without FIP. So it is not a reliable test to try and differentiate FIP in one particular patient versus a cat without FIP. And there are a number of healthy cats that can still have high or very high titers. And counterintuitively, there are a significant minority of cats, so about 10% of cats with FIP are actually seronegative to coronavirus antibody titers. And so while we can measure these things, I have to confess they're not something which I reach for very often in diagnosing cats with FIP. So we've done some blood tests. Maybe we think, based on our blood tests, that we have a high index of suspicion of FIP in a patient. It is still worth then considering some diagnostic imaging. And so, again, when we're doing imaging, I guess I'm just talking about tests which are easy to access. So things like X-ray and ultrasound. And often the easiest thing to try and look for with these tests is the evidence of some infusion or not. And cats can have effusions which are just in one part of the body, or they can be bicavitary. You can have small volume effusions, you can have large volume effusions, or anywhere in between. On abdominal ultrasound, we may also see lymphadenomegaly, keeping in mind, as I said earlier, we have an enteric coronavirus that is spreading systemically and it tends to go via the lymph nodes, and so they can often be enlarged. We're looking for evidence of granulomas in other organs. They're not always going to be obvious or able to be necessarily seen when you're imaging them, but I'm talking kind of granulomas in kidneys. It can affect one kidney or both kidneys. We can see granulomas in the large intestine and the ileocolic junction, as well as other abdominal organs. When it comes to thoracic radiography, there's actually not a whole lot published specifically for FIP outside effusions. There has been a recent paper published in Journal of Feline Medicine and Surgery, either earlier this year or last year, of about 35 cats which they had diagnosed with FIP, and there was a multitude of changes described, ranging from sternal lymphadenopathy, pulmonary parenchymal changes, as well as cardiomegaly, and some of these cats did have evidence of myocarditis on postmortem. And so if we've done our blood tests and some imaging, and we've got a suspicion of FIP, what to next? What do we do next? I think that logistically, if we have an effusion present, that's often the easiest thing to try and get a sample of to do some further testing on to help us either rule in or rule out FIP as a diagnosis. If there are other organ changes, particularly in the abdomen, I'm talking kind of maybe granulomas in a bit of intestine or a big lymph node or other changes, then sometimes we can do ultrasound-guided cytology and sampling that way. And then once we have those samples, we can do some more specific testing for FIP on them. So if we are able to get an effusion, what are the typical characteristics of this effusion that are most common with FIP? So most commonly, we can have a clear and viscous effusion, which is often a straw yellow colour and high in protein. However, cats can sometimes have other effusion types as well, such as chylous effusion. So cats just can have a range of different things. I feel like there's the common things, and then they still throw some other things in there just to keep us on our toes. If we were to spin some of that effusion and have a look at it under the microscope, there'll often be this proteinaceous background that we can see, and you can see that on that cytology picture there. It will typically be a high protein effusion, so we're talking greater than 35 grams per litre, and fit with the definition of an exudate. There is often a low to moderate cell count, and the types of cells that we're seeing are consistent with the pyogranulomatous inflammation. So macrophages, non-degenerate neutrophils, and a few lymphocytes. If we were to do some biochemical analysis of the effusion, it will typically mirror the serum. So if you have a low albumin globulin ratio in your serum, then typically that effusion will have a low albumin globulin ratio as well. And if we're measuring those acute phase proteins, again, that would typically mimic what's happening in the serum as well. So other tests that we can do on the effusion, you can do a Revolter's test. Now, a Revolter's test is a point of care assay that was initially developed to differentiate transudates from exudates. It's really important to know that a positive result isn't specific for FIP, and that positive results have been reported in cats without FIP. If you have a positive result that is consistent with FIP, however, the positive predictive value in one particular study, which was looking at effusions of in cats, of which over that total population, 35% of the effusions tested were cats with FIP. The positive predictive value in that population was only 58%. So it's not a particularly good test to try and rule in FIP. However, if it is a negative test in that same study, the negative predictive value was 93% for the exclusion of FIP. So it is a relatively quick test to do. And if it's negative, then it's helpful to try and rule out FIP. And what we're talking about when we're talking positive or negative is that you essentially have a very dilute acetic acid solution that you put a droplet of effusion in. And then the positive result is what you can see here, where the droplet kind of holds its shape when it gets put into that solution. And the negative result is when that drop disappears. Because it's just a visual test like this, it is quite subjective. And really, a positive result is just telling us that we have an exudate. Again, just to reiterate, this is not a test which is specific for FIP. Anything that causes an exudate can result in a positive Revolter's test. So FIP can cause a positive test result, but also any other disease process that causes exudate, such as septic peritonitis and lymphoma. So when we have an effusion sample, then it's really important that we do some cytology on it. And cytology, as well as histopathology, again, we're looking at a neutrophilic to pyogranulomatous inflammation. And we're seeing that inflammation in the absence of other infectious organisms that might also cause an inflammatory exudate. Cytology can be done of lymph nodes, effusions, organs, anything you can poke a needle into and get a few cells out of. And so, again, when we're doing cytology of any kind of sample out of a patient that we're suspicious has FIP, we're looking for that neutrophilic to pyogranulomatous inflammation. If we are collecting a CSF sample, so cerebral spinal fluid, similarly to our other changes on our blood tests and our effusions, the CSF sample of a cat with FIP will have a elevated protein content, as well as an increased cell count with pleocytosis. And aqueous humor, again, in cats with FIP, can have similar changes to CSF. The caveat I will put on, looking at CSF and aqueous humor in cats with FIP is that these are really samples that we might be collecting from a patient which has clinical signs in those particular organ systems. And so if you have a cat which just has effusive disease and no evidence of neurologic signs or no evidence of uveitis, then I would say it is not worthwhile trying to collect samples from these areas to have a look at, because our ability to obtain a positive test result increases if we're trying to collect samples from affected organs. If we're doing histopathology, that might be done with a TrueCut sample, ultrasound guided, or via surgical biopsy. Then the types of changes we're seeing with histopathology are a vasculitis with pyogranulomatous inflammation, and particularly CD4 positive lymphocytes. And so if there's one thing to take home with the type of inflammation that we're seeing in feline infectious peritonitis, it really is a sterile neutrophilic to pyogranulomatous inflammation. Okay, so just going back to this slide, considering what we're trying to do to get our diagnosis. So we've done some imaging. We've just discussed our non-specific testing for FIP and the types of changes which we might expect. So that high protein, fluid, pyogranulomatous inflammation in the absence of other infectious organisms. And so we're going to move on to more specific testing for coronavirus itself. So starting with immunostaining. And so the when we're doing immunostaining of feline coronavirus in macrophages, this is us trying to get a definitive diagnosis of FIP. So coronavirus doesn't live in macrophages normally, it should just live in the gut. And so if we're doing immunostaining, which is, if we're doing it on fluid or cytology, that is an immunocytochemistry, then that is really consistent with FIP infection. Immunohistochemistry is when we're doing immunostaining, looking for viral particles in macrophages within tissue samples, and that is our gold standard of diagnosis. Other specific tests for feline coronavirus that we can do are reverse transcriptase PCR for feline coronavirus in fluid or tissue. And tissue can be obtained as a cytology sample, so a needle aspirate, or pieces of tissue from from a histology sample. And what we're looking for with our reverse transcriptase PCR is the evidence of coronavirus within that tissue sample, and then maybe we can do some assessment of coronavirus mutations as well on top of that. As I discussed in the previous slide, it's really important that if we're going to try and get some samples from a patient which we suspect has FIP, it's really important that we try and sample lesional tissue. And so just going back to, because that will increase our chances of getting a positive test as well as our test accuracy and reduce the risk of a false negative. We do know that coronavirus can be unevenly spread in affected tissues. And so, as I said earlier, if the cat doesn't have neurologic clinical signs, and it's, sampling CSF is not a very good, way to try and obtain a diagnosis. So we'll start off with PCR testing, and the type of PCR testing we're doing is a reverse transcriptase PCR. And what the reverse transcriptase portion of that, or RT-PCR, is just describing the process, the additional process that you need to perform when you're trying to amplify a piece of RNA. So the reverse transcriptase allows transformation of RNA to DNA, which then, once you have a DNA sample, you can perform your regular PCR. And what we're trying to do by doing a PCR test is we're trying to amplify the coronavirus RNA. Accuracy of our tests really rely on the development of appropriate primers to bind the viral RNA. And remember that our coronavirus is a virus that has a high mutation rate. And so the development of primers is really essential to be able to have a sensitive and accurate test. And so when primers are developed, typically they'll be targeted to quite conserved areas of feline coronavirus so that reducing the risk of missing, having a primer that is in a highly variable area, so therefore you might miss that binding and then amplification. If we do a quantitative PCR, so that's when we're actually counting the number of cycles that are required to detect genetic material, you'll have a PCR that then gives you what we call a cycle threshold value, or CT value. The CT value is important to have a look at. If you have a sample that only requires a few cycles to before you're able to detect the presence of the virus, then that's telling us that we've actually got a high viral load. If you have to take a lot of cycles before you can detect that viral load, then that's telling us that that particular patient has a really low viral load, which as we know can happen with normal healthy cats. And so the take home with interpreting CT value when it's given to you from your test provider is that a low number means a high viral load and a high number means low viral load. So the advantage of PCR is that it can be done really quickly. So the test, which can be really important if we have a sick patient in front of us and we want to get an idea about whether or not FLP is a possibility for that patient. We want to know quickly whether or not we should be starting some treatment, some specific treatment. The downside to PCR is a positive PCR is still not in and of itself a definitive diagnosis. And just to reiterate, we can have healthy cats which have low numbers of circulating feline coronavirus. So we can run a PCR for feline coronavirus on just about any sample that you can put through a machine. It can be performed on blood, feces, effusions, tissue, aqueous humor, CSF. So you name it. If you can get it out of the patient, you can run that particular test. So it is good in that instance. And I will just go through some of the different ways that we can, or the pros and cons of testing different tissue types. Again, so we can talk about testing it on blood. Healthy can have low numbers of circulating feline coronavirus. Having a PCR positive blood test is not a particularly helpful thing, so I don't advocate for running our coronavirus PCR on blood samples. Again, when it comes to doing PCR on fecal samples, cats with FIP can be shedding coronavirus, but they don't always. And keep in mind that once the virus mutates to the systemic version, so an enteric coronavirus goes into a systemic FIP virus, they lose their ability to replicate in the gut. And so there is an application for PCR to look at, or identify chronic shedders, but it is not useful for identifying cats which have FIP. So for the purposes of FIP diagnosis, fecal PCR is not useful. One modality which is really useful is to do PCR on coronavirus effusions. It's really easy to perform because we've just got a fluid sample out of our patient, and the vast majority of cats which have FIP and an effusion will be positive for coronavirus in their effusion. And generally, cats which don't have FIP will be negative for coronavirus in their effusion. And so the take home for running a PCR for coronavirus in effusions for a patient is that if you have a patient that you already have a high suspicion of FIP based on its signalement, laboratory testing, including its blood tests and some imaging, and it's got fluid cytology, which is pyogranulomatous and no other organisms seen, it's high protein, and then you have a positive PCR and it's abdominal effusion, then that cat most likely has FIP. So we can do feline coronavirus PCR on tissue. It is a really good idea to have a chat to the laboratory as to the method of collection. We can get tissue a couple of different ways. From a non-invasive perspective, you can true cut lymph nodes to grab a bigger piece of tissue and do maybe some histopathology as well. We can also grab tissue via fine needle aspirate. It is better if we are going to do PCR that we don't do it on a formalin fixed sample, as formalin can degrade feline coronavirus RNA. And if we're going to do a coronavirus PCR on tissue, then it is still preferred that we do some kind of quantitative method. And there is still a possibility of a low possibility of false positive or a false negative. And perhaps unsurprisingly, when people have quantified feline coronavirus in cats with FIP, cats with more severe histopathologic changes had higher loads of FIP. When it comes to considering, running PCR on aspirates, then what you can potentially do is fine needle aspirate and then either put into some kind of RNA transport medium or saline. Again, this is where having a chat to your lab is a good idea because they will tell you what their preferred methodology is. And one of the advantages of FNA is that you can actually pool samples. And so that's where you might try, say, FNA out of a lymph node, liver, and the spleen and put it all in one tube, and then send that off all together to try and increase your likelihood of getting some virus that can be amplified. We can do PCR on CSF and aqueous humour. The consideration with collecting CSF is that sometimes these cats, because they have multifocal neurologic disease within their central nervous system, they can have increased intracranial pressure. And so when we're collecting CSF, we just don't want to accidentally cause a sudden decrease in intracranial pressure and herniation of the brain. And so again, and this goes down to kind of good test practices in general. So we'll increase the sensitivity if we have of PCR for feline coronavirus if we have a patient with neurologic clinical signs. And it's a very specific test. And so it is, if you have a patient which has neurosigns and you've collected CSF, then I think that and you're suspicious of that FIP might be one of your differential diagnoses, then it is good to do a PCR on that sample. One study that looked at the correlation of PCR positive CSF cats with coronavirus titers found that cats with high coronavirus antibody titers were more likely to have a positive PCR. And again, if you don't have a cat with signs of any kind of neurologic signs, then I would not advise collecting CSF to look for coronavirus. Again, when it comes to aqueous humor, this is a really interesting topic, and I think there is some more work to be done in this area. So uveitis is a really common presenting sign in feline infectious peritonitis. And feline infectious peritonitis is reported to be the cause of about 15% of cats presenting to ophthalmologists with uveitis. So it's a good portion of cats. Now, this recent study, which I've just popped on the slide here by Martinez and others, found that cats with systemic signs, so these are the cats that were systemically unwell, and cat tended to have higher feline coronavirus PCR than cats with no systemic signs, which were coronavirus positive. And so that's kind of a way of when you're quantifying the viral load, that is showing us that if you have a cat with uveitis, which is PCR positive, then maybe the eye is somewhere that the virus likes to hang out, and maybe it is a way that the virus then can spread to the rest of the body. I think one of the downsides of that study was that they didn't really have any follow-up of these cats. And I have to confess, when it comes to collecting aqueous humor, I don't tend to do that myself. I send a cat to an ophthalmologist to have that particular test done. So just to go over what we've looked at so far in terms of trying to make a diagnosis. So we've got a cat with consistent signalment history, examination, and our initial laboratory findings, and we found an effusion in them. And we've got an effusion that's consistent. And so when I say consistent, it's a high protein fluid. It has a low to moderate nucleated cell count. And the inflammatory cells are pyogranulomatous with no other infectious organisms seen or cultured. And in this case, I think PCR is a really good next step to perform, and we can have two potential outcomes. So we have a positive PCR, and then in which case that cat is highly likely to have feline infectious peritonitis. If we have a negative PCR, then that cat is much more unlikely to have feline infectious peritonitis. Okay, so the next part of the talk, I just want to have a bit of a chat about the gene mutations that can happen with feline infectious peritonitis. And so we'll just have a quick review of the pathogenesis. So keep in mind that when we're talking about the gene mutations that are associated with feline infectious peritonitis, we're talking about S protein gene mutations, and that's the spike protein. And the spike protein is what facilitates coronavirus to then enter the host cell. And it's the spike protein gene mutations that result in a coronavirus that has tropism for monocytes and macrophages over enterocytes that allows that systemic spread. And again, just remember that it's not just one mutation that results in FRP. There's likely a multitude of mutations that result in any particular case of FIP. So if we had an FIP-specific mutation, which only existed in FIP variant of coronavirus and not in any other situation, and we're able to pick it up or detect it, then that would be diagnostic. That would mean that we could identify that mutation and then go, yep, that patient definitely has FIP. We don't have a mutation that we've identified at this stage, which is entirely diagnostic, and it's probably because there is a multitude of mutations that occur in an individual that result in FlP infection. So the mutations in the spike gene, however, that occur at increased frequency in cats with FlP are the M1058L and the S1060A mutations. And the M1058L are the most common ones. So when we're trying to detect a spike gene mutation, we're doing that because we're trying to help us understand better, is this detection of coronavirus more likely to be associated with FlP or not? Detecting the mutation is an additional step, and you need to, the way that it is done is to sequence the spike gene. Now, there are different ways to sequence or identify these mutations. And in experimental setting, researchers will actually do really methodical sequencing of the whole area of the genome. That generally isn't what is done in commercial applications of these tests. And so sequencing actually requires generally the development of specific primers that to identify those single nucleotide polymorphisms that result in that spike gene protein mutation. There are instances where the sequencing of the spike gene is not always possible, and that can be when there's low levels of coronavirus. You just can't amplify enough to then be able to do the next step. And there may be sequence variability, or maybe in the case of a cat with FlP, you could have a different mutation or set of mutations that's involved in the development of disease. So sequencing is a good thing to do, but it's not necessarily, you're not necessarily able to do it in every instance. And so these gene markers were discovered by comparing feline coronavirus sequences in cats with FlP compared to feline coronavirus sequences from healthy cats without FlP in fecal samples. And so there was some pretty big studies done back in 2014 and 2017, which essentially did identify that these spike gene mutations, while most commonly seen with systemic feline coronavirus that they are spike gene mutations are seen with systemic feline coronavirus infection, but not just with FlP. Just again to remember that coronavirus can be systemically spread even in healthy cats without FlP. And so when we're doing that test, it is an additional step. And by doing the test, we will increase the specificity of our PCR testing a small amount. However, we can then potentially decrease the sensitivity of that test. It can be harder to pick up. So, and that kind of comes down to some of these cats where you have low numbers of coronavirus, so you can't necessarily do that next step. And so what are the practical applications of identifying spike gene mutations? And so just to be specific here with Glinix, the Glinix InCycle feline coronavirus or FlP mutation panel, it adds the methionine to leucine at 0.1058 detection on top of the standard feline coronavirus nucleic acid testing. And so by doing this, we're trying to improve the positive predictive value for FlP when feline coronavirus is detected. However, really importantly, it is possible that you can have a cat which is positive for feline coronavirus and negative for this particular mutation. Excuse me. And if you have all other clinical signs consistent and the absence of this mutation, then I think it's, and you don't have any other alternative diagnosis, it's still really important that we don't then just exclude FlP as a possibility for this patient. If you're PCR positive and everything else adds up to PCR, to FlP, then you still do have a high probability of FlP in that particular patient. So moving on from PCR and having a discussion around immunostaining. So immunostaining to detect feline coronavirus is where we're essentially using specific antibodies to try and identify coronavirus within macrophages in some tissue or fluid, essentially to demonstrate that this virus is present in this tissue when it shouldn't be there. And so if we have a positive on our immunostaining, that likely confirms FIP. However, a negative doesn't always exclude FIP. And some of the reasons for that can be because you can have variable distribution of feline coronavirus within tissue. And so if you've just unluckily sampled some tissue which doesn't have a whole lot of coronavirus, you can potentially miss picking up by immunostaining that evidence of that coronavirus. So immunocytochemistry is useful to do on effusions. And again, we're trying to stain macrophages within the effusion and identify the macrophages that contain coronavirus. It has been reported to have a very variable sensitivity, ranging from, just under 60% up to 100%. There is a possibility of a false negative as well. And that may be if you've got an infusion with a lower cell count, or possibly even keeping in mind that we're actually relying on, if I just go back a slide, we're relying on antibody binding of the coronavirus within the effusion in the macrophage. You can potentially have the cat's own antibodies binding the coronavirus antigen, and so therefore preventing your testing or fluorescing antibody to bind to that site as well. There has been some questions around specificity of immunocytochemistry, and there was a couple of studies published in 2013 and 2017 that had issues with false positives. And so these were kind of cats where they had immunostaining, but these cats did not have FIP. At the end of the day, it seems that when these studies were looked in a little bit more detail, there was poor methodology and storage of the samples, which may have affected their accuracy. And so the take home with immunostaining is that it really is laboratory and pathology dependent. And you also have to remember that most of the time, if you're requesting some immunostaining, you've still got a pathologist having a look down the microscope and then trying to find these fluorescing cells. And so sometimes that can just vary as to the pathologist, how long they spend looking for something like this. So immunostaining with immunohistochemistry. So this is where we have a tissue sample, which might be obtained via TrueCut or via surgical sampling, where we've got pyogranulomatous inflammation and then positive immunostaining of feline coronavirus in macrophages. And this, at the end of the day, is the gold standard of diagnosis of FIP. However, because it requires a tissue sampling, it is the most invasive way to try and diagnose FIP. And so while it's still kind of universally acknowledged that this is the gold standard, I think increasingly, particularly with the treatment options that we have nowadays, it's not something that we're often obtaining a diagnosis with immunohistochemistry. And like with all the other testing that we've done, when it comes to sampling tissue to try and get a diagnosis, sampling lesional tissue is really important. It will increase test accuracy and reduce the risk of a false negative. So only sample abnormal looking tissue. And so just as a revised kind of slide looking at how we make a diagnosis of FIP. So again, foundationally, it's really important that we have a signalment a history, a physical examination, and our preliminary blood tests that are consistent with FAP. Moving on from that, if we have some cytology that is suggestive of FAP, that might be via a fine needle aspirate sample of a lymph node or a kidney with a granuloma in it, then we can do a range of different tests. So cytology is still really important to do, but increasingly we can do our PCR testing. And if we're positive on PCR, and particularly if we have that spike gene mutation, then that's really suggestive of FRP infection. Other types of testing that we can do is immunocytochemistry or immunofluorescence. And again, that's staining coronavirus and macrophages. That is, if you have a good laboratory and a good pathologist, then that can be a very helpful test as well. If we have a histopathology sample, so that is a piece of tissue that we've obtained either a surgery or post-mortem, then again, we can still do PCR on that, which can give us a suspicion of FRP if it's positive, but the gold standard is immunohistochemistry. So let's head on now into some case examples. And so we'll go through quite a number of different cases, both of cats which had a diagnosis of FRP and some which just had disease that looked like FRP. And so we'll just start off with having a quick discussion around diseases that can mimic FRP. And so keeping in mind, so what we've discussed this evening has been FIP being a disease that causes vasculitis and inflammation. So any other disease that can affect multiple organ systems causing vasculitis and inflammation and effusions can mimic FIP. And so I've broken them down into infectious diseases and non-infectious diseases that can mimic FIP. And so when we're thinking about infectious diseases, so all of our infections that can cause multisystem disease. So we're talking toxoplasmosis, which is a protozoal parasite, cryptococcus, which is a fungal infection, mycobacteria, septic peritonitis and pyothorax, Feline and leukemia virus infections, and then hemoplasmosis as well, can all potentially have features of these infections that can mimic FIP. Non-infectious diseases tend to be inflammatory or cancerous. And so cancers that can mimic FIP especially are things like lymphoma, keeping in mind that lymphomas would be the most common multi-system cancer that we see in cats. We can also see carcinomas looking a lot like FIP as well. You can, at some instances, see cats with inflammatory liver disease. I'm talking lymphocytic plasmacytic cholangitis or neutrophilic cholangitis, cats with severe pancreatitis, and congestive heart failure certainly can be a reason for effusions in the chest and sometimes the abdomen as well. And so I think that when we're looking at this list of potential differential diagnoses of FIP, a lot of these disease processes have other specific findings which we'll see on the testing that I've already discussed to try and obtain that diagnosis for FIP. And so part of diagnosing FIP is having a patient with consistent presentation and diagnostic testing for FIP, but also along the way, not turning up a viable alternative diagnosis, which is resulting in the clinical signs you're seeing in that particular patient. And so really getting FIP as a definitive diagnosis based on a single test is really, really hard. However, each test that we do helps us to exclude other potential disease processes. And so really getting that diagnosis of FIP is really like putting together pieces of a puzzle. And so we've got collective evidence for FIP in the absence of an alternative diagnosis. And so we'll start with our first case. So this is Iggy. He was a 12-month-old male neuter domestic short hair, and he presented to the clinic with a history of a recent adoption from a shelter 4 weeks ago. The owner had actually been told by the shelter that he had been previously adopted out before she had obtained him, but that first home hadn't worked. So he'd been returned to the shelter and was there for a bit longer before she adopted him. He presented with a 1-week history of lethargy, poor appetite, and hiding behaviour. And in that 4-week period since he'd been adopted from the shelter, he'd had about 1 kilo in weight loss. So he was a pretty big cat. But 1 kilo in weight loss obviously is a really large amount of weight loss for a cat at any age or stage of their life. On his physical examination, he had some muscle wasting, particularly on his back. He had a fever with a body temperature of 40 degrees Celsius. His heart rate was 160 beats per minute and a respiratory rate of 32 breaths per minute. And so these were the preliminary blood tests that were performed. And you can see that he had some pretty classical changes, which we've discussed already for FAP. So you can see that his hematocrit is only sitting at 23% and a low hemoglobin. He does have a bit of a leukocytosis, which is predominantly because of a neutrophilia. His lymphocyte count is still normal, but it's kind of towards the lower end of the reference range. When we looked at his blood biochemistry, he did have an elevation of his total protein, and within that elevation was predominantly made up of a hyperglobulinemia sitting at 71 grams per litre. And then in contrast to that, his albumin was, again, still technically normal, but on the low end of that reference range. And so he had an albumin globulin ratio of 0.3. His abdominal ultrasound was relatively unremarkable, but he did have kind of a mild to moderate effusion. So some free fluid present, which you can see here. And he had some really prominent mesenteric lymph nodes. And so these lymph nodes still have some of their normal architecture, but they're just measuring large. And so he had a fluid sample taken from him under ultrasound guidance. And then this was his fluid analysis. And so he had kind of a moderate increase in cell count, and it was a pretty high protein effusion at 76 grams per litre. And when you look at the cytology of those cells, excuse me, so it's mostly neutrophils and macrophages, and the pathologist was unable to identify any kind of infectious organisms. Excuse me. And so we then ran a PCR for feline coronavirus on this fluid, and he was feline coronavirus PCR positive. He had the numbers on his fluid were too low to assess the spike gene mutation. But given that diagnosis, so we had a cat with a classical history, he was from a shelter, he had that stress of kind of being in a shelter and then rehomed and then returned to the shelter again. He had a fever, poor appetite, weight loss, classical changes on his blood test, and then consistent changes with his fluid analysis and a positive PCR. So we gave him a diagnosis of FRP, and I was pretty satisfied with that. So we'll move on to our next case example. So Suki, she was a 13-year-old female spay, domestic long hair. She had a more chronic history of 2 months of weight loss. She had these kind of itchy ears with crusting on the pinna. which seemed partially responsive to prednisolone. In recent history, she'd had a 2 weeks of reducing appetite, and the week prior to seeing myself, she had a bicavitary effusion documented at the local clinic. On physical examination, she had some muscle wasting over her back, and she was normothermic, and she had a palpable fluid wave. The local vet had done an abdominocentesis, and they just had a look at the sample in-house. And they'd noted that it was a light yellow fluid, clear, had total protein of 38 grams per litre, but no obvious cytological abnormalities. And these were the blood tests performed by the local vet. And so you can see here that almost every marker that was measured in this particular patient was normal, apart from that very mild elevation in creatinine kinase. And so I have to confess, if I have an obviously unwell patient with a really normal looking set of blood tests, then my concern for some kind of neoplasia or cancer in this patient actually goes up. And this is her chest x-ray, which you can see here, of which you can see that she has a kind of mild to moderate pleural effusion present. And so I did an abdominal ultrasound on this cat, as well as take some samples of some abnormal areas. So she had a large liver mass on the right-hand side. It potentially involved the gallbladder as well. She had a moderate to large amount of ascites. And she had this really thickened looking area of omentum. And so I took samples of the liver mass under ultrasound guidance, as well as the omentum and the free fluid. And when I sent those to the laboratory, if we look at the fluid analysis first, this is a fluid analysis, which if you look at the kind of criteria for diagnosis of feline infectious peritonitis, it is fits with that criteria. So we're talking about a moderate to high protein count. So that protein was 39 grams per litre. It was straw coloured, and it has, kind of low cell count. Now, and there were some inflammatory cells present. However, the things that were really not consistent came from the cytology. And so the pathologist identified carcinoma cells within the abdominal fluid, as well as the liver aspirate and the omentum. And so I didn't do an FIP PCR for this cat because I felt like we had our diagnosis. I could see that she was the wrong age. She was an older cat. She didn't have any blood test changes consistent with FIP or history of a fever or anything like that. We had a bicavitary effusion, which can happen in FIP, but then when we actually looked at the cytology of the fluid, there was just evidence of a malignant cancer. And I think that something which is a real take home is that sometimes it is good to rely on a pathologist to have a look at your cytology for you. This is a patient that perhaps if they'd sent that sample to the pathologist before she got referred to me, we might have saved her the trip to the referral clinician, because pathologists are just much better at identifying these types of abnormal cells. So her final diagnosis was abdominal carcinomatosis. Our third case was Toysha. She was a 5-month-old female spayed Burman. And so that signalment should ring alarm bells immediately. It's the right age. We've got a purebred cat. And she had presented to her vet because she'd had this history of coughing and poor appetite with a fever. And when the local vet did some blood tests, they were concerning for FIP. There was a high total protein, a hyperglobulinemia, and a mild anemia. The local vet had treated her with antibiotics in the form of amoxicillin clavulanate and meloxicam to try and reduce that fever. When she was referred to us, she did have a really marked increase in her respiratory effort with a restricted breathing pattern and harsh lung sounds. At that time, her body temperature was 37 degrees. And one of the reasons that she came in to see us was because she had had a deterioration in her overall clinical picture. And so here's her blood tests, which were performed by the local clinic. And so what we can see here, we've got a borderline anemia. We also have a leukocytosis. And so those are, consistent changes. However, things that kind of maybe a bit unusual, she didn't have a neutrophilia, and there was some suspicion of banned neutrophils. And she also had a lymphocytosis, which, remember, cats with FIP typically will have a lymphopenia rather than a lymphocytosis. As just a point of, note, these are blood tests which are run on an in-house machine. That machine couldn't count any platelets, and so they said that this cat had a low platelet count. If you ever experience this yourself, just a reminder that it's really important to have a look at a blood smear and check whether that's a true finding or just a machine error. When we look at her biochemistry, she had some pretty consistent changes with FIP there. So her total protein was a bit on the high side, and that was made up of an elevation in globulins with an albumin, which was still normal but lower end of the reference range, and an albumin globulin ratio of 0.4. She also had a mild elevation in her total bilirubin. And so there are some aspects of this hematology and biochemistry which are consistent with FIP, but some which aren't maybe quite consistent either. These are her thoracic radiographs, and I think I just want to point out a few things here. So she does have a moderate pleural effusion, but when you actually look closely, a lot of that pleural effusion is actually consolidated lung lobes. She does have also good serosal detour within her abdomen. So that suggests that if she does have an effusion there, it's going to be small volume or no effusion. We drained about 30 mils of fluid from this patient's chest, and it didn't really change her respiratory effort. 30 mils of fluid is not a large volume of effusion to take out from a cat's chest, which is presenting in respiratory distress. And so when we look at these thoracic radiographs, particularly in this right-hand side of the chest here, we can see quite marked pulmonary parenchymal changes, and we've got this air bronchogram and this alveolar pattern. And so it was thought that this cat, the effusion really wasn't the main reason for her respiratory distress. It was pulmonary parenchymal disease. The fluid that we obtained from this patient's chest, we did have a look at in clinic, and it was a high protein fluid at 63 grams per litre, and we could see macrophages, red cells, and neutrophils, and we couldn't see any other obvious infectious organisms. At this stage, given these changes with this particular patient, because there are some aspects of this patient which were really consistent with FIP, and that is the signalment and the history of the cat, as well as some of the blood test changes, but there are other things which didn't entirely fit, and that would be the degree of pulmonary parenchymal involvement. We do know that FIP can have pulmonary parenchymal involvement, but probably not to this degree, would be common. And as well, the fact that she didn't have a neutrophilia, and she had a lymphocytosis rather than lymphopenia. So sometimes in cases like this, particularly when we have a patient which is presenting quite sick and unwell, we will take samples and send them off to the lab and then treat supportively for whatever we can while we're waiting some test results. And so this patient, so she was admitted to the ICU. She was started on some FIP antivirals as well as antibiotics. And unfortunately, overnight, she deteriorated with her respiratory signs, and so she was humanely euthanized. So within the next few days, we obtained some more results. So she had a coronavirus PCR, which was performed in-house, and that was negative. We then also sent the fluid to the laboratory, and this was the fluid analysis that we got back. So it came back as a cell with, it was a kind of high cell count fluid with a reasonable amount of protein in it. And it was an inflammatory exudate. And when you look at the type of inflammatory cells, again, it was predominantly neutrophils, some macrophages. And you can see the comment from the pathologist is that while they didn't see any microorganisms, FIP was still of primary concern given the clinical history and the high fluid protein. We'd also sent this fluid for bacterial culture because the other kind of big cause of pleural effusion with pulmonary parenchymal disease is pyothoracus. And to our surprise, I have to confess, we cultured a nocardia species. And so the diagnosis for this patient, unfortunately, was a nocardia pyothorax, which we didn't get till after she passed away. And so I think this is an example of a case that while there are aspects of of the presentation which were consistent with FIP, at the end of the day, she was a cat that had a disease which really mimicked FIP in the way that it presented. So fourth case is Theodore. So he's a delightful 10-year-old malnourished Siberian cat. And he was a cat that had this really chronic history, I'm talking years of history of on and off diarrhea, which the owner had variably tried different diets with him to try and resolve that. But he presented to us because he became unwell. So he developed weight loss on top of his chronic diarrhea. He really had a large intestinal diarrhea, so blood and mucus and increase in frequency of passing stools. He also became lethargic and withdrawn, and his appetite became quite poor. On physical examination, he had quite marked muscle wasting and abdominal pain. He had some blood tests performed, and these were done by the local clinic. And there are a number of things here which are consistent with FIP. So we've got a cat with a mild anemia. He has a mild leukocytosis, which is made up predominantly of a neutrophilia. And again, his lymphocyte count is still normal, but it's towards the bottom end of the reference range. On his blood biochemistry, he has a low albumin, a high globulins, and an albumin-globulin ratio of 0.4. Everything else is relatively normal. But what doesn't make sense with this particular cat, probably more, is just his age of presentation. And so the next thing that we did, given that he was a cat with a history of large bowel diarrhea and weight loss, was we did an abdominal ultrasound. And he had some quite marked changes on his ultrasound. And so what we're seeing in this picture on this side is that this is his large bowel, his colon, and we've got a wall thickness of 7.8 millimeters. Generally, the colon wall should be less than 1.5 to 2 millimeters in width. And what we're also seeing in this portion of abnormal bowel is that we're losing the normal layering of the bowel, and it's just a more homogeneous looking piece of bowel. He also had some really prominent lymph nodes, which were bigger than they should be in his abdomen. So, and on top of that, he had a small volume of ascites. Given these changes, the main differential diagnosis for him, and this is based on age, were lymphoma and intestinal carcinoma. FIP was still on the list of possibilities because he did have some changes which were consistent with it, but his age just didn't, fit with the classical presentation, plus or minus a septic peritonitis, particularly if we're starting to see a small volume of ascites. So additional testing that we did, we measured a B12, which was normal, and then we took some fine needle aspirates of his colon wall, lymph node, and the fluid. So the fluid analysis. So we've got a pretty high cell count fluid, so 49.8 by 10 to the 9 per litre, and is a high protein fluid as well. And when we look at the actual inflammatory cells themselves, we've got kind of equal numbers of neutrophils and macrophages, maybe mesothelial cells, and then some small lymphocytes. And so no infectious organisms or other abnormal cells were seen, and so the interpretation there was a neutrophilic peritonitis. So we did a coronavirus PCR. So given the fact that we had those changes on his blood tests, as well as his gut and the fluid, and we didn't have a diagnosis of a cancer on cytology, it seemed reasonable to do a PCR as the next step. And we detected feline coronavirus, and it was the CT value of 15.77 is actually really quite low, which means that there were high numbers of viral particles there. And so his diagnosis was FIP. So he's a bit of an unusual case presentation of FIP because he's presenting as a more middle-aged older cat. But when we took his age out of it, everything else was really consistent with FIP. So we do sometimes see this disease in older patients as well. So you can't just rule out FIP just based on age alone. So case 5, this is Oreo. So he's a 3.5-year-old male-neutered domestic short hair. So he's kind of, from an FIP perspective, he's maybe a little bit older than the average, but still a kind of relatively young cat. So his kind of presenting complaints were a 1-week history of a fever, and he was initially diagnosed with a urinary tract infection and treated with antibiotics and a non-steroidal anti-inflammatory to try and resolve that fever. And on his blood test prior to presentation to our clinic, he did have an anemia sitting at 18%. He had a mild leukocytosis and a lymphocytosis with band neutrophils and a marginal hyperbilirubinemia. The albumin to globulin ratio was on the low side, but both albumin and globulin were within the reference range. On physical examination, he was a bit dehydrated. He did have quite a marked fever at 40.3 degrees, and he had some cranial abdominal pain. And so something I want to draw your attention to, so these were blood tests that then were repeated within the clinic after presentation. So he did have some really marked toxic changes in his neutrophils, which I would say doesn't typically happen in every cat with FIP. He did have that anemia, which is consistent with cats with FIP, and at this point he did have a lymphopenia as well. When we go across and have a look at his blood biochemistry, he did have some changes which are consistent with FIP. So he had a mild hyperbilirubinemia, but then on the tests at this point in time, his protein levels were actually well normal, kind of mid-range reference range normal. Again, with normal albumin and globulin ratio of 0.8. Interesting to note, he does have a mild elevation in his CK, so his creatine kinase and AST. Now, they're both muscle enzymes, AST also from the liver, but that's worth just having in the back of your head for this particular patient. So this cat was quite a memorable case because he did stay in hospital for quite a while. So we felt with the tests that we'd done so far, we didn't really have an answer as to why he had this persistent fever. So we did some abdominal imaging. He did have evidence of a renal infarct and a mild pylectasia in the left kidney, some hyperechoic mesentery around his left limb of his pancreas. Maybe that was what was causing his abdominal pain. His abdominal lymph nodes were enlarged. And we did have, often these cats went in hospital for a while and we don't have a in, a good understanding of why they're unwell, we will tend to repeat tests. And so we could see that these changes were persistent. Thoracic radiographs were performed, and he had a mild to moderate diffuse bronchointerstitial lung pattern. And this seemed to worsen while he was in hospital. At no point did he really have any specific respiratory signs, but we could see that there was disease going on in his pulmonary parenchyma. His urine protein creatinine was borderline proteinuric. He was urine culture negative. And when we repeated tests down the track, he had this really persistent neutrophilia with left shift and toxic changes. And over this whole time, his total protein remained normal. So over these 4 days, he had a range of treatments. He had intravenous fluids to try and help bring his fever down. He had some pain relief because he was sore. We escalated his antibiotics till he was on full quadrant coverage for gram-positive, gram-negatives, and anaerobes, and he still had a persistent fever in hospital, and we didn't have a diagnosis as to why. This is just one of his chest films that we took. And so because he had these persistent changes in his chest, we did discuss with the owner tests such as CT scans, BL and bronchoscopy, and then maybe ultrasound-guided aspirates of his liver, spleen, and lymph node. And the rationale for that is just trying to get some tissue samples in a non-invasive way to try and do cytology and then maybe some more specific testing. The owner declined CT and BAL, but agreed to liver, spleen, and lymph node cytology. As you can imagine, because this was a really long stay, the owner was kind of running out of money to treat this particular patient. When we saw the cytology from our abdominal sampling, so the lymph node, liver, and spleen all came back as reactive and inflammatory. And you can see the comment from the pathologist, discussing probably an infectious process, not specific for FIP, but FIP is a possibility. They couldn't see any obvious infectious agents. And so at that point in time, when we had done a lot of different testing, we'd taken samples, both blood samples as well as tissue samples from this particular patient. While there were some aspects which might be consistent with FIP, this patient never had any really consistent changes in its blood proteins in terms of hyperglobulinemia and hypoalbuminemia. And this patient also had these kind of quite marked pulmonary parenchymal changes, which would be atypical for FIP infection. And so we elected a treatment trial as follows. So we placed an esophagostomy tube so that we could get good control of nutrition as well as medication. And we started antiprotozoal medications. We kept up his antibiotics for the time being. He stayed on some pain relief, as well as meropenem and mirtazapine to help support any kind of nausea and improve his appetite as much as possible. We had a suspicion of toxoplasmosis in this patient, mainly based on the fact that we had evidence of multi-system disease, but not changes which are really consistent with FIP and a lot of his biochemistry. And so the outcome for little Oreo was that he just improved. And so as he improved, we de-escalated his medicine. So he was after a week or two, he was really only on his antiprotozoal medicines. And when we repeated some of his imaging, he had marked improvement in his thoracic radiographs, as well as his overall demeanor, resolution of his fever, and as all that inflammation in his abdomen settled down as well. And so the fever only really resolved after starting. With some aspects of multi-system disease, we had a presumed diagnosis of systemic toxoplasmosis, and that was based on the fact that he had response to antiprotozoals and that was the only thing which he seemed to respond to. He didn't respond to kind of regular antibiotics. So let's move on to some treatment updates. And so what we're going to go through here are some different drugs that are used to treat FIP. And as I said earlier in the talk, we're just going to really focus on the newer antivirals that have been developed and have been shown to be effective in FIP. And so when we're thinking about principles of treatment of FIP, coronavirus-specific antivirals are really important. But on top of that, supportive care for these patients as well, depending on how unwell they are. So things like IV fluids and antibiotics and enteral feeding and things like that. So there are a range of different ways that antivirals can target different viral organisms. The ones that have been reported and that we'll really talk about today, we'll briefly touch on the protease inhibitor GC376, and that's because that was really the first antiviral that showed any effect in cats with FIP. But then we'll mainly focus on GS441524 and remdesivir, which are related drugs, as well as molnupiravir. And so GC376 is a viral protease inhibitor. It was first described in 2016 in cats with an experimental infection. And what was really remarkable with these cats was that there were cats that recovered from their experimental infection, which up until this time hadn't really happened. So 6 of the 8 cats which had experimental infection that were followed for 8 months did really well. They did show that this drug doesn't penetrate the CSF very well. And there was one cat that died 6 months after publication with neurosigns. So it's probably because that drug isn't very good at getting into the CSF. And then in 2019, there was a field study done by Niels Petersen, who's a researcher who's done a large amount of work around FIP and treatment of FIP. And in the majority of these cats, so these are naturally infected cats, their clinical signs improved. The 12 cats had resolution of signs, and remission times took between 3 and 17 weeks, and 6 of these cats had long-term remission. And so at this point in time in 2019, this was a pretty amazing finding. There was a large number of cats, so 13 out of the 19 did relapse. And however, when they looked at cats which were more likely to be have a positive response, they were the younger cats, and there was a 30% long-term survival. Then in the same year, in 2019, Niels Petersen also published a field study on 31 cats, with using a drug GS441524, which I shall just now refer to as GS. And they did have some variable dosing with this particular drug with these cats, and the majority of the cats had effusive form. 5 cats had only dry form, but there was a good number of cats that did really well. So 25 out of those 31 cats were long-term survivors. They did find that they kept on having to increase the dose of the drug. And there was 18 cats still alive at the time of publication. And there were a decent number of cats that relapsed, but for those cats, then they restarted treatment at a higher dose, and then some of those cats did respond again. So this again was groundbreaking in 2019 when we had evidence of a drug being so effective. Initially in 2019, the report was that despite good response to GS, we were never going to see it in commercially because of the company that developed it not wanting to release it for veterinary use, which was both kind of just a devastating thing to know. And then, as we've all experienced, the COVID-19 pandemic meant that research into coronavirus antivirals just skyrocketed. And then we had just a lot more access to these medicines. And so there was a recent, rather than going through a whole bunch of different studies, there was a really recent review into the efficacy of GS44 for treatment of FIP. And this review put together 11 different studies which treated 605 cats. These cats were treated with GS alone or sometimes in combination with other antivirals. And their overall treatment success was 84%. Interestingly, they had lower success in effusive disease. And so the success in neurologic disease was only 68%. And then if you combine that to a patient which had combined neuro and ocular disease, that success dropped to 43%. One of the reasons for that is that just drugs, a lot of drugs can have difficulty to pass the blood-brain barrier and the blood-ocular barrier, which means that if you have coronavirus hiding out in your brain or your eye, it can be harder for drugs to penetrate and to treat. So other drugs used in this study included feline interferon omega, molnupiravir, GC376, and remdesivir. And so you can see, because this was a review of treatments, these aren't there was no standardized treatment regime across this population of 605 cats. So I think now that we have a large body of work published on GS44, there have been some pretty good treatment recommendations which are kind of out there for people to be able to read and to use to treat their patients. And the big thing with these antivirals is that the type of disease that we've got does affect the drug duration as well as the drug doses that we're using. And so depending on how sick your patient is, it is important that they are treated with any kind of supportive care depending on their clinical signs. So if they're really dehydrated and unwell, some IV fluids. If they're painful somewhere, some analgesia, maybe some antiemetics, maybe appetite stimulants, and that'll depend on the case-by-case basis. Again, brain disease and eye disease is harder to treat because the drug has more difficulty penetrating those areas, and so therefore we need higher doses. And so you can see that, and I use kind of remdesivir and GS interchangeably. Remdesivir in Australia is available as an injectable and GS is an oral, but remdesivir is a prodrug of GS44. And so if you have wet form FIP, you're probably okay at 10 milligrams per kilogram once a day. Dry and ophthalmic is probably more like 15 milligrams per kilogram once a day. And then once we've got neuro or central neuro disease, then we really need to consider 20 milligrams per kilogram once a day or divided daily. The side effects of the remdesivir is that it can cause pain on subcutaneous injection. So, which is a consideration. So it can also be given as a slow IV injection. Molnupiravir is also another nucleoside analog and antiviral. It is, however, more mutagenic than GS and remdesivir. And so in this retrospective study of 26, which was really an owner survey, this drug was predominantly being used as a rescue therapy post using some other kind of antivirals in the majority of cats, but in 4 cats it was used as an initial treatment. There was good response to this drug. The majority of cats were alive at the time of publication. However, this drug had more side effects, particularly in the form of hepatopathy and bone marrow suppression and cartilage weakness with folding ears. And these side effects seem to be quite dose dependent. So the higher the dose that you used, the more likely you were to result in side effects. That was the initial study published. There had been more case series of treatment published, kind of both here from Australia as well as overseas. And the response rates seem to be comparable to GS44 and remdesivir. The dose range is 10 to 15 milligrams per kilogram twice daily. And again, just to remember that the therapeutic dose and toxic dose are much closer together. This drug, at least in Australia, we can get legally. We can also get compounded GS and remdesivir, but because it's compounded, it's more expensive. So accessibility to some of these antivirals, depending on where you are in the world, will be dependent on the local, licensing and registration. And so I've just popped this graph up here. This was published by an Australian researcher in Journal of Veterinary Internal Medicine a couple of years ago. And what is really nice to look at with this graph is just what's happening with some kind of really important variables of treatment success. So we can see that the globulins are dropping. So we've got on the x-axis, we've got the treatment weeks, and the y-axis is the kind of numbers. And so you can document that these are cats with effusion, that it took them on average a couple of weeks for that effusion to resolve, and then their globulins actually increased in that time. It's thought that's probably because the cats are, while they're getting treated and successfully treated, their body's absorbing all those globulins from the high globulin infusion, so it makes their blood globulin level go up. And so you can see that their globulins actually go up before they start to drop back down into the normal reference range. This middle line here is the packed cell volume, and you can see that that kind of mild anemia is improving, and then their body weight, again, typically would drop a little bit and then kind of return back to normal. And so when do we adjust treatment? And these are some guidelines put together to try and understand. So if we think we've got a cat, we've diagnosed its FIP, and maybe things aren't going to plan, or like how long do you have to wait before you change your treatment regime? And so if the cat is persistently inappetent or pyrexic for more than a week or so, if their effusions are present for more than 2 weeks, if their white blood cell abnormalities persist or its bilirubin persists for more than 3 weeks, if the hyperglobulinemia can be one of the last things to resolve, it can take 6 to 8 weeks to resolve, or the albumin-globulin ratio isn't resolving, or, and this is the caveat here, like development of new signs referable to FIP at any time, then we should be doing a treatment adjustment. The nice thing about GS and remdesivir is that these drugs seem to be very safe. Really, the only side effect I can think of described with them, apart from pain on injection site, has been if cats are given really large amounts of these drugs, which is what has happened with some of the black market drug where there's unknown concentrations. There have been cats reported with a cystolith, which has been made up of entirely of GS, but because it's excreted by the kidneys. But if we're using a drug concentration where we know the concentration and we're worried that the cat isn't responding as well as we'd like or is relapsing, then we should increase that dose 3 to 5 milligrams per kilogram. Another consideration would be the addition of a second antiviral such as molnupiravir. So if we've got a cat being treated for FIP, like how do we monitor what's going on? Ideally, we would have serum biochemistry and hematology after 2 weeks of treatment and then once a month. This can be a pretty costly thing to do, a lot of blood tests and revisits to the clinic. So other ways that you can maybe in a more affordable way monitor these cats can be just their body weight and their general clinical picture. Are they becoming really fat and happy? Is their red cell count returning to normal? Are their protein levels just on an in-house TP on a refractometer, is that returning back to normal? You can also do some monitoring effusions if you know what you're doing and you're handy with an ultrasound machine to document that we're seeing resolution of abdominal effusions. And so I'll just go through some of the treatment for our first case. So this was Iggy. So he was the young cat from the shelter who we had a diagnosis of FIP, and he was a really classical presentation. So he ended up in hospital getting rehydrated for 48 hours. We did try to kickstart his treatment with a couple of doses of intravenous remdesivir. Because he was a wet form, he just had the 10 milligrams per kilogram once a day. And then he had 1 week of oral GS44. And then we actually transitioned him to oral molnupiravir. And that was based on the cost of these drugs. Just as a bit of perspective, in Australia, the cost of 4 months of GS44, 3 to 4 months of GS44 could be up to $8,000 or $9,000, whereas that same amount of oral molnupiravir may only be $500 to $1,000. So for some people, the cost plays a role in their drug in their decision around which drug they're going to use. So he was much better clinically after 1 week, and his behaviour had returned back to normal. He was eating a lot better. We saw him again 1 month after starting his medicine, and then 1 month after finishing his treatment at 84 days, and he had a return to his pre-FIP body weight. And this is just a little photo of him at his last visit. He was a bit of a nervous boy, and he was just trying to hide in the cupboard, but you can see he's got a nice amount of condition on his backside there. So if we've got a cat where we're treating them for FIP and we're worried about treatment failure, it is just keeping in the back of your mind that resistance is possible to antivirals. Like anything, coronavirus does mutate. But as well, you've probably got to just ask yourself, have I definitely got a diagnosis of FIP in this patient? If the cat is on GS44, this is a really safe drug, so it's easy to increase a dose and safe to increase a dose 3 to 5 milligrams per day and then continue and then monitor and make sure that we're getting the type of response that we want. We could also consider the addition of a second antiviral. I would have the same approach if we're worried about a relapse, so that maybe the cat was doing quite well and then it fell in you seem to go backwards and have the same clinical signs. So we might consider restarting at a higher dose and maybe repeating that 84-day course at a higher dose as well. So how long do we need to treat these cats for? So the current recommendations are 84 days. And the rationale for that is that 84 days is the life of a tissue macrophage. And so we're trying to make sure that that cat is on its antivirals for the entire time that there could be any kind of macrophages that are containing feline coronavirus. Ideally, we confirm that the patient is in remission before we stop treatment. And we only want to stop treatment once we have a normal patient for at least 2 weeks. And then we need to monitor that patient for about 12 weeks to make sure that they're staying as a normal cat. And again, ideally, we'll repeat bloods and imaging 2 to 4 weeks after stopping treatment. So this is our last case for today. And this is a case of Squire. So he was a 1.5-year-old male neuter Bengal. And I've included him in here just because there's some aspects of his case which were really quite interesting. So he had a several-day history of ataxia and a bilateral uveitis with a history of then, in the preceding weeks, some weight loss. He was obtained as a kitten from a breeder, and the owner had described him as always being runty. She did own another cat and so knew what a normal cat should look like, and he was just always a bit on the small side. On his physical examination, he had really reduced muscle condition, dull mentation. He was ambulatory but with gross ataxia falling to the right side, and he had a borderline fever with a temperature of 39.2 degrees. And in this photo, you can really see, probably more obvious in this eye, but you can see that kind of iris change, and he had a little bit of some precipitates just on the inside of that cornea, as well as just mildly, you can see them on the inside of that cornea as well. So in his hematology, he had a mild anemia. His biochemistry had a really severe hyperglobulinemia with his globulins of 106 grams per litre and an albumin globulin ratio of 0.2. His abdominal ultrasound revealed general lymphadenomegaly and multifocal areas of his gastrointestinal tract, stomach, small intestine, large intestine, with an increased wall thickness, splenomegaly, but no free fluid. And the cytology of the lymph node was reactive. And so I guess our differential diagnosis was for him was, I say lymphoma was there, but then also FAP and toxoplasmosis. And if we look at how often we see these two different diseases, FAP, we would see, a huge number more cats with FAP over toxoplasma. And so he was started on some FAP antivirals, and that was based on the fact that he was a pedigree cat. He was the right age. He had a really severe hypoglobulinemia. He had multisystem disease involving his brain, his eyes, and his abdomen, and the absence of evidence of another disease process. So the aspirates, I would have thought that if he had a lymphoma going on, we should have picked that up in the aspirates. And so treatment consisted of supportive care, remdesivir, for 4 doses, and then we transitioned him on to that higher dose of GS44 because he had neuro disease. He actually had an esophagostomy tube placed because the owner was unable to medicate him orally, and if anybody's owned a Bengal, they'll know exactly why the owner was unable to medicate him orally. They can be pretty flighty cats. It took him a couple of months to normalize his albumin globulin ratio. However, there was some concern around persistent uveitis, so he was actually transitioned on to molnupiravir twice a day for a further 3 months. And this is him after he had recovered. So he had a full recovery, which is really nice. And the owner actually felt that he was healthier after treatment than he had been before treatment. And so he was a cat that I would be worried that maybe there was that battle between the coronavirus and his immune system in his body, and it took him eventually developed into FIP, but by getting rid of his coronavirus, we actually made him a really happy cat. And so in this case as well, even though we had no specific coronavirus tests which were positive, we had the patient as a whole ticked pretty much every box for diagnosing FIP. And then he responded to antiviral treatment. And so, I think that, with him, I have, without a doubt in my mind, he had FIP and he had an excellent response, thankfully, which supported that diagnosis of FIP. So other considerations with FIP, when we're treating these cats, we need to avoid prednisolone if we're using antivirals because they kind of work in opposition to each other. Any other supportive medications should be okay. So fluids and meropitant, mirtazapine, analgesics, that type of thing. It's really important to try and avoid stress, knowing that the important role that stress plays in the pathogenesis of this disease. And I would avoid any kind of elective stresses. So things like desexing or putting the cat in a boarding cattery or introducing another cat to the house. Let's try and avoid all of those things until we've completed our course of antivirals. These cats should be okay for vaccination once they have recovered, but do it after they've been healthy and well for a few months after completion of their course of antivirals. And in Australia, at least, because we have a lot of tick and flea problems, you can still maintain all their other prophylaxis while they're being treated. That's the end. So thank you very much, and we're happy to answer some questions.
Okay, thank you so much, Dr. Jukes, for such an insightful presentation. And we have been received some excellent questions from our audience. So let's move on to the Q&A session. So for the first question from our viewers is the question from Dr. Sam Lee. And allow me to have a read of it. I have a case of a cat with abdominal and thyroid effusion. Although the clinical condition is visibly improved, the cat looks more pink and healthier. The blood test readout show that the red blood cells and HCT have a slightly decreased compared to the initial evaluation. And PLT has also dropped a little bit. Previously, the PLT level was not decreased at the first time. And thank you. And should I have a pay attention to or add anything else for her treatment in the following week? And yeah, this is our
Okay.
first question.
Yeah, thanks for this question. I think it is really important to look at your numbers as well as your patient. So what the patient is doing clinically is arguably just as important as what your numbers are doing. And I think for this question, it really depends on the degree of the changes that you're seeing. So if you and as well, doing red blood cell counts and hematocrits, it can depend on your methodology of doing these things as well. So my general impression would be, if these have just been done on in-house analyzers, and you also need to consider whether the patient is sedated or not, because or whether the machine that you're using to do the tests is the same. So if you're trying to compare, and this is not just applicable to FIP, but if you're trying to compare measuring hematocrit and red blood cell counts at the laboratory machine compared to your in-house machine, even if you were to run it on the same sample, you might get different numbers. If you are to have a patient that is sedated and you've taken a blood sample to measure these things, you can sedation, the spleen can kind of sequester red cells when the cat is sedated, and so you can have an artificially low red blood cell count for that reason. So and as well, as I said, the degree of what's going on. So if you have a cat that maybe has had a hematocrit go from 28 to 25, I'm not really worried about that. If it's gone from 28 to 18, well, that's something which is quite different. And so we might just need to repeat that test. In terms of platelets as well, it depends on whether you're measuring them on the machine or whether you're looking at a smear in-house, or whether you're sending a CBC to a laboratory and having a pathologist look at those counts for you. It's pretty common, like cat platelets will tend to, they clump really easily. So I find, because my preference is to do my hematology on the machine at the laboratory, because then I get a pathologist to have a look at my morphology of my cells. And so, it is pretty common from the lab that they don't actually give me a platelet count, other than to say platelets are clumped and adequate. And I think that's kind of a cat thing to do. So if you're ever in doubt with something like platelets, it doesn't take very long to make a smear in-house and just check what they're going on. So if the cat, I would say, I guess in summary for that particular cat, these hematology changes you need to just kind of think about the things I've talked about. You might need to repeat a test to confirm, but also most importantly, look at what the patient's doing. So you've got that confirmed diagnosis of FIP and these changes are mild and your patient's doing really well, then you're on the right track.
Okay, thank you so much for your answer, Dr. Jukes. And we got another question from Dr. Amira. And this question is actually pretty long, so allow me to finish the reading. Hi, doctor. I would like to ask whether you have encountered a case of effusive form concurrent with neural form FFA. Recently, I got one case of white form FFA responded to treatment of GF zinc injection. On day 30, the cat started to develop neural sign, starting with reduced tail tone, hind limb paresis, and self-mutating syndrome. There were acute progress signs of neuroscience, progressive towards the forelimbs, and eventually, after 3 days, the cat started to have anorexia, head tilt, and seizure. Based on symptoms, I suspect a neuroform FFA that leads to the myelomycia. Unfortunately, due to cost constraint, the owner refused to further testing, and the cat could not make it even though we adjust with the neural FFP dosage. Sorry for the long elaboration. Is it possible the cat infect with both wet form and neural form FFP concurrently? Dr. Amira.
Okay, so the short answer is, well, maybe there's not a short answer. Cats, I would say with neuro FIP, it's not common that they have concurrent effusive form when they have when they're presenting with neuro FIP. In saying that, if they had a wet form that either wasn't adequately treated or maybe had a mutation and there was some antiviral resistance, cats which have had a previous form of FIP can then relapse with a different form of disease. So if this cat's effusive disease looked like it was much improved, I think, it's I guess it's not clear from the question, but it sounds like the effusion was improving and then the cat developed neurologic signs. And so I think that, things that if you truly have a suspicion that this is an FIP that is either resistant to the antiviral that you've used and you're happy that you're using an adequate dose. And so this is where it does come down to, like, a lot of the detail with treatment success comes down to the dose. And so with those neurocats, as we looked at with that last case that we had, we really want to have them on at least 20 milligrams of GS44 per day. At that dose rate, you probably will end up dividing it. It does seem to be a very safe drug. And so if you think that this cat's developed neuroscience on that, we could still look at increasing that another, 5 milligrams per kilogram, maybe up to 25 milligrams per kilogram, or we could consider adding in another antiviral, so something like molnupiravir as well. And I do understand, trying to do investigation for cats with neuro disease can be pretty costly. I would be curious to know what the cat's biochemistry is doing and hematology. Like, are we seeing other signs consistent with FIP there? I think the tricky thing with neurocats is that as a variant of the FIP disease, because if the virus is just hanging out in the central nervous system, sometimes you don't see like some cats you'll see really marked changes on their blood tests, but other cats, I feel like I've had a suspicion of FIP, even though their blood tests haven't necessarily been really classical, and it might be based on being a young cat and not being able to find anything else in imaging. And so there are still some of these cats, or I feel like I didn't have enough evidence to put them into a presentation like this tonight. But you still have a suspicion of FIP. But the thing is, you just got to make sure that your dose of your drug is appropriate. And if you think it is, then you might need to expand your antiviral use.
Thank you for your very detailed answer, Dr. Jukes. And we got the third question from FANZCVS. After we stopped the GS injection for 1 month, neutrophil is high, but clinically the cat looks healthy and gain weight. Is that normal?
Okay, so probably a little bit like my response to that first question about red blood cell count and platelet and things like that. It probably depends on the degree of what we're seeing. So if we have a mild, mature neutrophilia, there's no toxic changes or a left shift, sometimes you kind of need to send those samples to the lab to get more detail on neutrophil morphology or be comfortable at looking at your blood smear in-house. And so I think that if you have a mild neutrophilia in a cat that's and everything else looks like it's resolved, I'm not too worried about that, because there's just so many things that can cause a mild neutrophilia. If it's a really kind of more moderate to severe neutrophilia, or we've got other concerning changes, like some toxic changes to those neutrophils, suggesting that they're unhappy or fighting infection, or we've got a left shift telling us that the bone marrow is kind of working harder to get those neutrophils out because there's a consumptive process going on, but the cat has no other signs of FAP, then that's probably an indication to do a little bit more looking around to see whether or not it is a relapse, or whether there's just another disease process that's going on. I think that as well, but again, if the cat's really, really happy and well, maybe you just retest its bloods in another month or two's time, and see what's going on there.
And thank you so much, Dr. Jukes. We got our last question from Dr. Shima. Thank you, doctor, for the very informative lecture. What is the recommended medication in case wet FIP form with pleasure effusion and has long parenchyma involvement? Also, he has a secondary IMHA and thrombocytopenia.
Okay. So there has actually been a recent paper looking at the cats with FIP and concurrent IMHA, which is thought to be secondary to the FIP. From personal experience, and this was a paper, it was retrospective, and there was a number of these cats that ended up on some prednisolone as well as their antivirals, and maybe they had a worse prognosis, but from memory, I think it was only about 40 or 50 cats, so it wasn't huge numbers. And so it's a little bit hard to interpret 60% versus 70% in a small cohort, from larger studies and success rates. In terms of, from my personal experience, having had a couple of cats, so not huge numbers, but a couple of cats which potentially fulfilled the criteria of a secondary IMHA with their FIP, my approach to those cats has been to treat them really aggressively with supportive care and antivirals. And so far, I haven't had a cat that I felt I've needed to use immunosuppressives on just yet, because resolving the FIP and treating it meant that helped to resolve their thrombocytopenia and anemia. And I'm talking about resolution within, or kind of not necessarily that kind of hematocrit and platelet count returning to normal, but within a week, these cats are clinically stable and not require, you're not feeling like you need to reach for corticosteroids as well. I guess I would just be checking. Hopefully, we've got a confirmed diagnosis. My feeling is that extensive pulmonary parenchymal disease as part of FIP is not a particularly common presentation. I think, so if you've got a cat that just looks like it's got a pyothorax, kind of like the case that I presented, so a cat like that, I would just want to kind of, be sure that we're treating the right disease process. If we have a really sick and unwell patient, I'm more likely to be doing more tests to try and rule out an unusual infection or cancer or something else which might cause a similar looking presentation.
Thank you so much, Dr. Jukes. And We got another further question from Dr. Sam Lee, which is the
That was our
Dr.
first
Reese,
question.
our first question.
Yep. You're the
Sorry,
hematopit. Yep.
we decided to just extend our question a
That's
little
good.
bit. Sorry, this is the question from Dr. Sam Lee. Could it be possible that I've used too much omega 369 causing the PLT to drop? I've been running CBC tests for her every week and biochemistry tests every 2 weeks. The ultrasound in the first week showed that the amount of fluid had visibly decreased by about 60%.
So what was the drug? Omega. Is that an interferon?
369.
I'm just not familiar. Is that because there's the I'm just not quite sure what that medicine is. Can you Kevin, do you mind just popping it into the chat so I can?
That will be okay, Dr. Jukes. And since we have the time limitation, and we will just ask the very detailed question from Dr. Sam, and then we can just feed her back later after today's online session.
Happy to do that.
And thank you once again, Dr. Jukes, for sharing your valuable experience and expertise. And thanks to all of you spending your time with us today. We hope this session has provide practical insights and renewed confidence in the managing FLP case in your clinics. So to watch the replay or stay updated in the upcoming G-Links webinars, please please just following our YouTube and Facebook account. Have a wonderful day, and thank you for your time. If you have any further question, doctors, and please just feed it back to our regional managers or salespeople, and we will collect those questions and answer them one by one. Thank you so much. Thank you, Dr. Jukes. Thank you for your time.
Thank you.
Bye-bye.